Thank you for joining my presentation on the effects of obesity on lung function. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures. All of our lectures are AARC approved, and all of them give you continuous education towards your license. I want you to enjoy this presentation, and I'm hoping that you'll learn a lot from it. Today's objectives will speak about some of the statistics on obesity here in America. I'm going to talk about the prevalence of comorbidities when patients are obese. I'm going to talk about how it impacts lung function. I'm going to talk about some anatomical differences between someone who has normal weight versus an obese patient. I'm going to talk about airway management because dealing with patients who are obese is a little bit different about intubation strategies and so on. I'm going to also be talking about ventilator settings. Sometimes you have to adapt the ventilator to the patient. And I'm going to talk about a very important maneuver with obese patients, the recruitment maneuver. A lot of times these patients have collapsed alveolar, and the only way to pop them open is to do a recruitment maneuver and offer the proper PEEP afterwards. And then I'm going to talk about what is known as obesity paradox. I'm not going to get ahead of myself, but I'm going to tell you all about this as we go along. The worldwide prevalence of obesity has been on the rise in the past 3 decades. Over the last 30 years, people are getting bigger and bigger, resulting in an increase in the prevalence, morbidity, and clinical presentations of many respiratory diseases. Obesity has been tied in to respiratory disorders. Obesity is an important risk factor and a disease modifier for asthma, obstructive sleep apnea, obesity of hypoventilation syndrome, pulmonary hypertension, and it actually can impact the outcome of patients who end up getting ARDS or COPD. Obesity increases the susceptibility of respiratory infections, also increases hospitalization rates, and also has an increase in respiratory disease compared to normal weight patients. So obesity is a problem for America. We're getting bigger and bigger, and we need to come up with strategies to lose weight. That's number one, but this is not about weight loss. But if you happen to have a patient in your hospital who is obese, there's a certain way to manage them, and this is what this whole presentation is about. So before we get much further, I wanted to give you a chart that we use here to determine whether someone is obese. And basically, it's called based on what they call body mass index, which takes into consideration your height and your weight. And based upon that, they came up with this general scale to determine whether you're obese or not. Currently, if you are less than 18.5 BMI, that means that you are underweight. If you are healthy weight, you would be anywhere from 18.5 to 24.9. And you can see that we have other categories of being overweight, obesity, and then severe obesity. Sad to say, many patients who come into the hospital have a BMI greater than 40. And as a result of that, they have a bunch of comorbidities, which we're going to get into. So this is a chart we based our weight on. And, sometimes I feel it's a little bit unfair because some people work out all the time and they can be very muscular and they are not necessarily, they're in higher BMI, but they have a small waist. And there is some evidence showing that small waist circumference is a benefit to the patient or the person. It doesn't have to be a patient with a small waist. So, but this is the general guidelines that they go by, and we are an obese country for sure. So let's talk about the statistics of obesity in America. I showed you the chart before. With adults over the age of 20, over 42% of them are considered obese. And here's really another category. With the patients who are age 20 and over, who are overweight, including obesity, is almost 74%. So that tells you that over 74% of America are considered to be obese. In regard to children and adolescents, which is really a problem, with children between the ages of 12 and 19, 21% of them are obese. With children between the ages of 6 and 11, 20% of them are obese. And look at this, with the ages of children between the ages of 2 and 5, 13% of them are obese. So what does this all mean? What does this mean in regard to the care of these patients? So let me give you a little bit idea of the cost involved with the care of these patients. Obesity has taken a huge toll on the healthcare costs across this country. It's estimated that we spend approximately $147 billion a year for direct and indirect health care with patients who are obese. The medical cost for individuals with obesity is calculated to be around $1,400 higher than those who are with normal weight. That's per year. And then another time, when you look at lifetime medical cost, if you get a 10-year-old who's obese, it costs approximately $19,000 more to care for that child until it reaches the age of an adult compared to a normal child. When multiplied by the number of 10-year-olds in America, the expense for health care for children who are 10 years old is approximately $14 billion in this country. So, besides the kids getting heavier and becoming obese, there's huge medical expenses that occur with it. So we really got to do something with these stats. It's not very good in this country, and it's only getting worse. Myself included, I could definitely use some weight loss, and luckily I dropped about 20 pounds over the last year. Have another 15 pounds as my goal, but it's a problem. We live a sedentary lifestyle. A lot of us don't exercise, and the comorbidities involved with being obese is staggering. So these are some stats that you could think about. I wanted to bring to your attention a study that was conducted in 2018 at Jersey Shore University Medical Center, which is in Neptune, New Jersey. And what they were looking at, they wanted to see of a certain amount of patients who were admitted in the hospital over a given period of time. They wanted to see how many of them were obese, and more importantly, what kind of comorbidities did they have. So they did this retrospective chart review, and they measured the BMI as per the CDC, and they measured to see if they were obese, if they had any kind of comorbidities such as hypertension, diabetes, hyperlipidemia, coronary artery disease, congestive heart failure, chronic kidney disease, and COPD. So they were looking at all these different things, and they were also looking at the length of stay of these hospitals for these patients. In other words, did the obese population end up staying in the hospital longer than the normal group? So what they did was they looked at 540 consecutive admissions to the hospital. The average age of this group was 66 years plus or minus. They found that out of the 540 patients who were admitted to the hospital, only 34% represented normal weight. The other 66% were obese, or were they morbidly obese. Another finding from this study was that 55% of the obese group were females versus 45% for males. Not picking on any sex, I'm just giving you the facts. They also looked at if any of these patients who were obese in the hospital received any kind of counseling about weight loss, and they found that only 2% of the group received any kind of counseling. 98% received no counseling at all. And then they looked at the prevalence of comorbidities such as hypertension and so on. And some of the findings were that hypertension was in 68% of the group, diabetes type 2 was in 35% of the group, hyperlipidemia was in 36% of the group, and coronary artery disease was in 18% of the group. And of the COPDers, 24% of them were COPDers. In regard to length of stay, they found kind of surprisingly that the length of stay for a normal weight versus an obese patient was quite the same. In other words, the typical stay in this particular population, this particular study, was 4.5 days plus or minus 0.5 days. So my next slide is going to go a little bit more into the comorbidities that exist with being obese. And this was a nice little snapshot of America. This happened to be just a city in New Jersey, a hospital, university hospital in New Jersey, but this could be applied to probably many other states. And there are some states which have a bigger obesity rate or a higher obesity rate than other states. And there are some states have a lower, like California, Colorado have a very low obesity rate, where mostly in the South, the Southeast, the part of this country, there's a lot of obese patients. So we'll go on to the next slide so you learn more. This particular table represents a comorbidity list of those 540 patients that were did a cohort study on. And some of the things I like to mention to you is that there are certain things that are more prevalent, certain comorbidities that are more prevalent with being obese. For example, the percentage of patients who were obese with hypertension greatly increases. Also, another factor is if you look at diabetes, you know, the more your weight goes up, the more likely you are to have diabetes. So it's a big, like 24% versus 15% right here. And another thing is hyperlipidemia, where, you know, if you have a normal body weight, it's normally 29% versus if you're obese, it's up to 34%. Very interestingly, the category of obese versus overweight, people who are overweight, who could be, you know, 10, 15 pounds overweight, are very susceptible to getting type of comorbidities such as hypertension, diabetes, hyperlipidemia, and so on. So, you know, it's not just being morbidly obese that this occurs to. Just being obese or just being like overweight has a significant impact too. So this was a little idea of why we want to control our weight, why we don't want to be, you know, we want to try to stay as close to normal body weight as we can. And if you don't, the likelihood of you getting these type of comorbidities is pretty high. So you can extrapolate these findings to the general population. I wanted to bring to your attention another study that was produced by Morbidity and Mortality Weekly Report, and it was published in March of 2021. Basically, what they were looking at, they looked at over 238 different hospitals across the country, and of that, they looked at approximately 148,000 patients who were admitted. No, let me rephrase that. They looked at 148,000 patients who entered into the emergency room because they felt they had COVID. Of those group, 71,000 of them were hospitalized. And they found, what is the reason for hospitalization? They found most of the patients who were hospitalized were obese, and those who were not hospitalized had a BMI under 25, which is basically a healthy weight. So the pattern here was that if you were obese or overweight and you had COVID, you were more likely to be admitted to the hospital, and being admitted to the hospital means there's more likely to be put on mechanical ventilation, and it also increases your mortality. So they were looking at some of the reasons why this was happening, and they felt that if you are obese, basically you have chronic inflammation in your body, and this inflammation disrupts the body's immune response and impairs lung function. So they believe being obese has some kind of inflammatory process in the body, and this inflammatory process impairs your immune system, and that is more likely why they are admitted, and more likely why they're put on mechanical ventilation, and more likely why they're going to die. So kind of interesting, the relationship between COVID and being overweight and obese.
Hi, I'd like to talk about the changes in respiratory physiology that can be seen with obesity. Something to remember with obesity is that there are both mechanical effects as well as biochemical effects. Mechanical effects from excess weight of adiposity result in a decreased compliance of the respiratory system. This also causes some impairment in VQ matching. Biochemically, obese individuals have an increased oxygen consumption, and alveolar hypoventilation is also a problem. We'll look at each of these in turn. The most consistent measurable change for patients that are obese is a reduction in the functional residual capacity. This graph shows the decrease in functional residual capacity with an increasing BMI. Another way to conceptualize this is that the respiratory compliance has been decreased. There's a shift of the pressure volume curve towards the right in the obese individual. In other words, it takes more pressure to generate the same change in volume. When pulmonary function tests are measured in obese patients, you typically see actually normal FEV1 and FVC measures. Again, the hallmark reduction here is a reduction in functional residual capacity. Even so, total lung capacity usually is normal. Residual volume also usually remains within the normal range, but there tends to be a marked decrease in the expiratory reserve volume. We'll talk a little bit more about this. Among other PFTs, diffusing capacity also typically remains normal. And in the extremely obese patients, it's been noted that DLCO might actually be elevated. The exact mechanism is not well known, but possibly due to an increase in blood volume. So let's look more at functional residual capacity. Remember that this volume is a set volume based upon the compliance of the chest wall and the lungs. This dashed line shows the compliance of the chest wall among different ranges of pressure and the pressure volume curve that's generated. This dashed line shows the same thing for the lung tissue. At FRC, when these forces are at balance, the chest wall is tending to produce an outward pressure, or a pressure to expand the lung, and the lung tissue itself is tending to create an inward recoil pressure, or a tendency to collapse. At the end of expiration, these two forces are balanced and you have the functional residual capacity. In the obese individual, the chest wall is weighed down by excess adiposity, and this pressure volume curve is shifted to the right. This means that the balance between these forces is a little bit lower, and that's why functional residual capacity is decreased. There are some significant implications of reduced functional residual capacity. One is that the expiratory flow rates are reduced. Another way to say this and see this is that airway resistance is increased. We expect this. In fact, this is normal at lower lung volumes because the cross-sectional area of the airways is smaller. There's less tethering by surrounding lung tissue. However, the specific resistance of the airways is normal, suggesting that the airways themselves are not the problem. At extreme levels of obesity and extreme reductions in FRC, even tidal breathing can encroach upon the closing volume. This can lead to air trapping that increases in the lower lobes and regional mismatches in ventilation and perfusion. The end result of this can be that there's hypoxemia and an increased AA gradient. In fact, recent studies have shown that a mild to moderate shunt is present in the morbidly obese patient. There's abnormal blood flow to the area, to the lung tissue, and this VQ matching can be demonstrated by a multiple inert gas elimination technique. In this example of a single patient, the red circles represent pulmonary blood flow, and the open circles represent ventilation. You can see that before surgery, there's a 6% shunt present, and this significantly reduces after bariatric surgery has occurred and significant weight loss along with it. Let's shift gears and talk a little bit about hypercapnia. Obesity can cause hypercapnia through a few different mechanisms. Obesity causes a resistance to leptin. It causes an increased mechanical load and can weaken respiratory muscles over time. And of course, obesity is a major risk factor for obstructive sleep apnea. These three things together all can lead to a blunted ventilatory response and the presence of chronic hypercapnia. Chronic hypercapnia is not a good thing. Very briefly, you can see in this graph, obesity patients that also have hypercapnia are significantly more likely to be dead after a hospitalization when followed over time. You can see the probability of survival significantly different between those patients with obesity that are eukapnic and those that have hypercapnia with obesity or the obesity hypoventilation syndrome. Related to exercise, interestingly enough, the VO2 max for obese patients is typically normal as long as they otherwise have normal cardiopulmonary systems. However, the specific values for oxygen consumption and minute ventilation are greater for subjects that are obese at specific work rates. In other words, it takes the obese patient more effort to do the same amount of work. So in summary, obesity causes mechanical and biochemical effects in the lung. There's a decrease in respiratory compliance, predominantly created by excess adiposity around the chest wall. Functional residual capacity can also decrease. Along with that is a pattern of a severe decrease in the expiratory reserve volume. It's not only the chest wall that does this, but also increasing pressures on the abdominal contents, compressing the diaphragm. Low lung capacity and diffusing capacity are often normal, and there is the presence of VQ mismatching that can cause hypoxemia. Lastly, hypercapnia can occur, and when it does, it's not a good thing. Thanks for your attention.
The previous video did a great job of explaining some of the physiology and pathology of compressed lung volumes with obesity, but I wanted to get a little bit more into different anatomical and physiologic differences between a normal lung and a patient with an obesity. So common findings in an obese patient is a larger sagittal lung axis, which that means is the area from the sternum to the ventricle, which is like, from front chest to back chest is typically larger. And basically you get a shorter longitudinal axis, which means apex to base. What that means is because your stomach presses up against your diaphragm, the amount of area that you could breathe is limited because of the adipose tissue pushing up against the diaphragm. Also, adipose tissue compresses the chest wall and diaphragm, leading to pulmonary restriction, which I just mentioned over there. Another thing is it takes more pressure to ventilate a patient who's obese versus a normal, because you have to compensate for the adipose tissue being displaced by mechanical ventilator with the pressure given to the lung. Typically, they have a reduced functional residual capacity. There's increased narrowing of the upper airway, and the reason for that, typically people who are obese have a bigger neck, and that bigger neck comes from adipose tissue in the neck. And actually that occludes the airway, so the more adipose tissue, the more fat in the neck, it pushes up against the trachea, and it actually narrows it, giving a restrictive process to the lung. A lot of times with these patients, because of that restrictive pattern during the day, they could compensate with muscles in the neck to keep the airway open, but when they go to sleep, that area relaxes, and that is why people who are obese are more predisposed to getting obstructive sleep apnea. Also, there's a decrease in static lung volumes, FRC, residual volumes, and this is caused by atelectic tissue basically caused by alveolar collapse. So these are some of the common findings with obese patients. Also, the prevalence of OSA in patients with metabolic syndrome is estimated to be as high as 60%. So obesity, OSA are hand in hand. And all of this leads to possibility of getting pulmonary hypertension, specifically from impairment of the right heart. So these are some of the anatomical differences and some of the physiologic responses that occur as a result of being obese. And I'm going to get a lot more into it as we go along. I think this is a great slide that will show you um, lung volumes of a normal patient versus an obese patient. And some of the common features you see is, number one, total lung capacity. The area from here down to here is greatly reduced with a morbidly obese patient. Other changes is changes in static lung volumes. So what do I mean by static lung volumes? I'm talking about your FRC, your ERV. Both of these are markedly reduced. Also, your tidal volumes are reduced, and so many different features are reduced. They found that because you have a smaller volume of gas, so that would be considered a restrictive pattern. So you might have, and this is caused by airway closure, and airway closure is caused by alveolar collapse and air trapping. Typically, your total lung capacity, your FRC, your reserve volume are all decreased. Your FEV1 and your vital capacity is also reduced, but your FEV1 to vital capacity is normal. So I think this graph actually gives a great presentation of exactly the differences between a normal lung and a morbidly obese lung. And with that in mind, when you put them on mechanical ventilation, you really have to sort of apply different strategies, which I'm going to get a little bit more into later. What is the relationship between DLCO and obesity? The DLCO, which stands for diffusing capacity of carbon monoxide, is a very common test given in the PFT lab. And there are a couple of theories going out there in regard to obese patients. As you can see by the upper right graph, you have your normal values, you have your elevated values, you have your reduced values. So theoretically, which there are two school of thoughts, but I'm going to give you the main school of thought. They believe that obese patients have an increased diffusing capacity, and the reason for that is because they have an increase in total pulmonary blood volume and flow versus the average patient. There's another side to the equation where they believe you have reduced values of DLCO, and they believe that is caused by structural changes in the alveolar wall due to lipid deposition. Basically, you have fat deposits on the alveolar, which will impair the diffusion of gases across the alveolar membrane. So you have this two school of thoughts. One school of thought is you have increased diffusion capacity, and the other thought is that you might have less. But I would say most of the evidence has shown that it is an increase in diffusing capacity as well. And this also goes for asthmatic patients. And there is a relationship between asthmatic patients and obesity. So another school of thought. You probably have seen these charts for a long time, how people have two different types of shapes, either your apple-shaped or android or your pear-shaped gynoid. Basically, there's a lot of research showing that people who have the apple shape typically are more predisposed to diabetes and heart disease versus the pear-shaped. Typically, it occurs more often with men than women. Typically, it correlates with metabolic syndrome versus the pear-shaped. We're going to talk a little bit first about the pear-shaped. In the past, pear-shaped people basically got a green card. It's okay if you're pear-shaped. You're not going to get heart disease. You're not going to get diabetes. Don't worry about it. It's only the people with the apple shape that are having issues. But new evidence has shown that's not true. People with pear-shaped are predisposed to get heart disease and diabetes. So the best thing to do if you're pear-shaped is to diet and do some exercise. But the real horror story comes with the Android shape or the Apple shape. Typically, people who have a lot of fat around the abdomen, this fat just doesn't end around the outer part of your body. It actually encompasses organs inside your stomach tract, and it sort of encloses your organs with fat. As a result of that, you are predisposed to metabolic syndrome because it has a strong influence on your metabolism. Basically, fatty acids and other substances are released in the blood from this area, and a lot of this causes an inflammatory response, like also the release of cytokines. So people with the apple shape really need to get on board about with some kind of diet plan or some kind of exercise plan, or probably a combination of both. Now, here's another thing. If you happen to have an apple shape, but you are not overweight, in other words, if your BMI is less than 25, but you've got a little bit of a belly, evidence has shown that this is not good. Actually, even if you have a correct BMI, you're not overweight, but you got sort of a belly there, that again predisposes you to diabetes, metabolic syndrome, and a host of other conditions such as cancer and cardiovascular disease. So that's the good news and the bad news. The good news is that you can do something about it and change it. And we must have all heard about how waist size and circumference is a relative marker for metabolic syndrome and being obese and all the things that go along with it. So get on board, get on that treadmill, walk around the block, do things you got to do. So you bring your patient into the OR, and they're going to intubate the patient. And if it happens to be a morbidly obese patient, you think it's going to be a little difficult? Of course it is. So there are certain techniques that you could use to intubate these patients, and I'm going to talk about them on the next slide. I wanted to get into some guidelines that could be used for intubations. And some of the things you gotta look for, especially with the morbidly obese patient, is neck circumference. That is the single best factor to predict a difficult intubation or not. And some of the signs of a big neck is like if you have your neck circumference is around 40 centimeters, the likelihood of that being a difficult intubation is very low. If you have a 60 centimeter neck circumference, the likelihood of that being a problematic intubation is like 35%. So the larger the neck circumference, the greater likelihood is going to be a difficult intubation. And some of the other key factors you got to look for, most males have big necks. Also, a higher Malapati score is a very, very important part. Anyone who has a history of obstructive sleep apnea is another factor. So with those cases, you really want to sort of determine a Malapati score. And basically, when you get into class 3 and class 4, which has very poor visualization of the vocal cords, that's when you want to use a video laryngoscope or have an LMA standby. So once the patient's intubated and put on mechanical ventilation, now we're going to talk about strategies to manage the patient on the ventilator. So you have someone in the ICU, and either they're intubated or they're on non-invasive ventilation. What kind of strategy would you use? It definitely would be different than a patient with normal weight. You have to use the appropriate strategy, the appropriate settings to manage these patients properly, and also you don't want to create no harm. So I'm going to go a little bit into the details of the management of these patients on mechanical ventilation. Before we go much into how to ventilate a patient who's obese, I wanted to give you a quick look at the lungs and the impact of adipose tissue on the lungs. On the left, you have a normal lung. And what you have is you have your diaphragms over here, and you have your normal lung field. So when you ventilate someone like this, it's pretty straightforward. It's everything you learned in school. Now, the difference is when you ventilate someone who is morbidly obese, what happens is they have a lot of adipose tissue right here underneath the diaphragm, which actually pushes up on the diaphragm, which reduces the functional residual capacity. So what that means is that you cannot take a deep breath. Also, this contributes to airway closure and collapse, where the alveolus don't get actually fully open and ventilated. So you have a lot of shunting going on there. And the second part of this I wanted to show you is when you have adipose tissue around the chest wall, say around this chest wall on obviously both sides, the fat that is around the chest wall will impede ventilation. So what that results in is a decrease in compliance. What does that mean? When you have a decrease in compliance and that you have collapsed alveola, that means you need to come up with ventilation strategies that work for this particular patient. And there are some very good ways of doing it, and I'm going to explain all that to you in a little bit. I wanted to talk about a very important topic with obese patients, and that is called tidal volume. The image on the upper right shows you have an obese patient, and in most cases, the assumption is that you could give them a bigger tidal volume based on their weight. I mean, I know we all know that you cannot give a tidal volume based on, the body's weight. You really have to use a formula. And most of the well-known studies out there, like the ARMOR study, which looked at ARDS and acute lung injury, and also you have other studies by the alveolar study, and all of them want to use the formula for predicted body weight, which is located right here. So you could see the formula right there. It varies between man and woman. But it's a pretty simple formula, and once you calculate their predicted body weight, then you could start off with a tidal volume which is more acceptable. And a good acceptable tidal volume is approximately 6 milliliters per kilogram. The idea of limiting tidal volume has been shown to decrease the ventilator-associated lung injury, and when you do that, you actually decrease inflammation in non-selected patients with or without ARDS. The idea of normalizing a tidal volume for predicted body weight has been shown to be very beneficial to the patient, less ventilator days. Also, if you implement this very early, the patient has a better outcome. The morbidity and mortality decreases too. And another important factor is that, like I said, you predict the predicted body weight. You give them a tidal volume about 6 cc's per kilogram, 6 milliliters per kilogram. If you position the patient in a ramped or sitting position, basically it unloads the diaphragm and decreases the abdominal pressure, and it can improve aeration of dependent lung fields. So basically, don't put an obese patient flat on their back, because their abdomen will be pushed up, their fat will be pushed up against the diaphragm, and it impedes ventilation. Also, the earlier you start spontaneous ventilation on these patients, the better. So what does that mean? That means you put them on pressure support, and you get them to ventilate themselves, because that's a very important factor. So understanding tidal volumes and using the predicted body weight formula is a very good way to start with managing your patient. Earlier, I was mentioning how difficult it is to intubate these patients, but I just want to stress this again, because this is really important. As you know, for all the reasons why obese patients have difficult intubations, the fat around the neck, the Malapati scores being really severe, So you must anticipate that you will be using sedatives and possibly neuromuscular blockades during this procedure. And the reason for this is because you can anticipate this being a bad intubation or difficult intubation. Another very important step is to pre-oxygenate the patient. I couldn't stress enough how much it's important to actually increase their oxygen reserve. Again, be ready with some video laryngoscopes and other supraglottic devices that need to be ready in case something goes wrong. And a lot of times these patients have some form of hemodynamic impairment during intubation. Again, you need to have fluids and vasoactive drugs in case something like this happens. So these are very important safety features, especially with the obese patient. So now that the patient is intubated and you want to put them on mechanical ventilation, I'm going to tell you some initial settings you could do in some initial modes. First of all, you can lower the FiO2. There's no reason at all to hyperoxygenate the patient because this only increases free radicals and increases inflammation. So the goal is lower your FiO2 and just keep your SATs above 90. That's a good starting point. Second thing is, you know your tidal volume is based on predicted body weight, and you want to target a tidal volume anywhere from 4 to 6 cc's per kilogram if you suspect ARDS, or 6 to 8 for non-ARDS patients. Another important factor is you want to use a volume mode or a volume target ventilation rather than pressure control ventilation. Due to the fact that they have so much external pressure and their compliance issues is due to adipose tissue, it's nice to know that you get a predicted tidal volume, because if you have someone who's morbidly obese and they're on mechanical ventilation and you put them in a different position, suppose you roll them over to your left or you roll them over to your right, this displaces your stomach up against the diaphragm, which could impact the tidal volume being delivered. So if you had a fixed pressure of, say, 27 centimeters of pressure in the lung, and now they have some kind of positional change, that 27 centimeters may not give you the predicted tidal volume you're looking for. So that is why you really want to use a volume mode, or you could use a volume targeted mode, which is available in some ventilators. Initially, you're going to start with a low to moderate PEEP, anywhere from 5 to 8 centimeters of water, and then you could titrate the PEEP based upon your blood gas. And I'm going to get a little bit more into adjusting these settings. These are your initial settings you would set up for a patient who's on mechanical ventilation. So let's start talking about, now that you got the patient on some initial settings and you get a blood gas and you want to, set the vent up properly for the patient to make sure that you are using it in the best way. Most obese patients can benefit from a PaO2 of anywhere from 55 to 80, or a SAT of anywhere from 88 to 94. So you don't really need to bump up the FiO2 to get them a SAT of 98. Another very important thing is a lot of these patients have air trapping, which results in intrinsic PEEP. So the idea is you need to use strategies to reduce the likelihood of intrinsic PEEP, and you might want to measure it. Some of the signs of intrinsic PEEP could be that you have a high respiratory rate. So if you have a high respiratory rate, the patient doesn't have much time to exhale and release all the gases, which results in air trapping, which again results in intrinsic PEEP. So the idea is to keep the respiratory rate kind of low, that this way the intrinsic PEEP is removed. Another strategy with intrinsic PEEP is sometimes to increase your PEEP level like 1 or 2 above your intrinsic PEEP level. So suppose you do a measurement for your intrinsic PEEP and your intrinsic PEEP comes out to 7. You may want to set your PEEP to 8 or 9, and this would actually improve the quality of aeration to the alveolar. Another thing you need to monitor is driving pressures. driving pressure is the change between plateau pressures and PEEP, and you want to sort of keep that level about 17 centimeters of water for ARDS patients, and you want to keep that level about 15 centimeters for non-ARDS patients. And the reason you want to do this is this helps you prevent ventilator-induced lung injury. If your patient is persistently hypoxic, you may want to use higher PEEP levels. So the first choice to see if you have chronic hypoxemia is to increase the PEEP. So these are some of your general guidelines you need to do, and I'm sure you guys all know how to do this. I wanted to talk about some strategies if your patient is not doing as well as you anticipate. And there's a few things that we can do. First of all, the concept of using recruitment maneuvers on these patients is sort of, there's two schools of thought. Some think it's good, some think it's bad. My next slide is going to be talking more about recruitment maneuvers, but I would consider that as part of my tools and something if the patient's not responding well. A second thing, if the patient is becoming hypoxic, you really don't want to increase the FiO2 to 100%, or you don't even want to be above 60%. So basically what you want to do is create a stepwise increase in PEEP levels and look and see how the patient responds. And if you don't see any kind of hemodynamic compromise or decrease in venous return, then you're in a good place. So consider using PEEP and consider keeping the FiO2 at a level of about 60%. Some studies have shown that with the obese patients, typical PEEP levels could be anywhere from 10 to 26 with an average about 18. So, you got to realize that PEEP actually splints the airway open on these patients, and there's a lot of compression from the obese factor of their chest, and that's why they have decreased compliance. So sometimes PEEP works very well. Prone positioning, no reason why. If you have a patient who's obese and they are an ARDS, proning is not a problem at all. Whatever your protocol is for proning, it's good, no problem. Another thing is most extubation attempts on this population benefit from the use of non-invasive ventilation after you extubate them. So in other words, don't just plan to extubate them to a venti mask or some other type of mask. You may want to consider using non-invasive ventilation as a bridge to extubation. As I was mentioning earlier, the use of a recruitment maneuver with the obese population is kind of controversial. Some people swear by it, some people don't. A lot of institutions are using esophageal pressure monitoring to set their PEEP level, also to conduct recruitment maneuvers. But I want to tell you a little bit about both sides of it. There's been some studies that have shown the recruitment maneuver works very well. That is because it takes higher opening pressures to open up the alveola. But one of the most important things with the recruitment maneuver is to put adequate PEEP after the maneuver. Because the opening pressure of the alveola is higher than the pressure needed to keep them open, the application of initial recruitment maneuver followed by adequate PEEP after intubation is very important. Problem is, due to the high pleural pressures in these patients, because of the obesity, opening pressures can be up to 50 centimeters of pressure to get a recruitment maneuver to work. In other words, it takes sometimes up to 50 centimeters of pressure to actually pop open those collapsed alveola. The problem with that is that these high pressures could probably decrease venous return and thus decrease cardiac preload and actually have an impact on cardiac output. So, due to the hemodynamic issues with these high pressures needed to do a recruitment maneuver on these patients properly, it represents a problem. On top of that, there's a possibility of doing some kind of barotrauma or ventilator-induced lung injury on these patients with these high pressures. So it's kind of controversial. Um, you got mixed studies each way doing it, but I've heard many places are using esophageal pressure monitoring to actually create adequate PEEP and also to use with recruitment maneuvers not to overly inflate the lung. So I think each hospital has its own particular set of values for this. I wanted to go a little bit more deeper into PEEP. And the use of PEEP in the obese population is actually to improve alveolar de-recruitment. More than actually recruiting the alveolar, it prevents the de-recruitment of the alveolar. So the idea is to keep the alveolar pressure above closing pressures, which these particular patients have a very high closing pressure. So the problem with this, with PEEP, and why it's needed is because you have this superimposed pressure transmitted by adipose tissue on the pleural space. So what that means, it takes more pressure to pop open those alveolar. Studies have shown that PEEP ranges anywhere from 10 to 26. I mentioned this earlier, with a median of 18 centimeters. Some places have used esophageal balloons to actually measure pleural pressure and come up with the correct PEEP. So I would say that you have to understand that the closing pressures are higher with this population, and this is one of the major reasons why you have to add additional PEEP to actually splint open the compliance issues with the adipose tissue on the chest wall. So PEEP is very useful, and a lot of times if you treat a patient who's obese with the normal PEEP levels you would do for a normal patient, you're not going to get the results you want, and you probably have a little hypoxemia, and that's not the best thing for the patient. I know this is a little bit off the beaten path of what we've been talking about, but when I was putting together this presentation and reviewing the science with obesity, I came across this concept called Obesity Paradox. And if you go to any kind of Medline or Google Scholar and you look it up, you're going to see a whole host of things. So what that means, obesity paradox, is that people who are obese, who are coming to the hospital, have certain survivability advantages over a normal person. So it almost pays to be obese. Certain conditions benefit from being obese and in the hospital. For example, the survivability rate of anyone with coronary heart disease or chronic heart failure or stroke is much better if you are above normal weight. Also, COPDers benefit from the fact of having more adipose tissue. So they were looking to find out exactly what is going on with these, and what they did, they originally were looking at patients with ARDS, and they were finding that patients with ARDS who happened to be overweight and obese had a better survivability versus a normal weight person, and they call this obesity paradox. And they're doing a lot of research on this. I actually think I'm going to put together a good presentation on obesity paradox, and I think it's kind of interesting. But basically what they feel is that patients who are obese have more metabolic reserve and can tolerate stress to the body better than a normal weight person. They believe also that they have better energy stores in the form of adipose tissue for this, while your body's under stress, they have more energy stores of adipose tissue. They can tolerate different stress levels in the body better than a normal weight, and even better than someone who's underweight. So very interesting topic. It's called Obesity Paradox, and I just thought I'd throw it out there for you. In summary, I want to thank you very much for joining my presentation, and I got some take-home points. Overall, obese patients are more likely to develop complications during the hospital stay, except for the list I just showed you before with the obesity paradox. Managing the airway can be very difficult with these patients for all the reasons I mentioned. They have a lot of fat deposits. The Malaparte scores are really kind of high. Another concern is once they're intubated, they're more prone to alveolar collapse, and that has to do with a lot of compression factor on the pleural space. Because of that, you need to use higher PEEPs. You may want to consider recruitment maneuvers, and more importantly than anything, when you do put the patient on a ventilator, use a predicted body weight to set the tidal volume. And I hope you enjoyed this presentation. And like I said, I think I'm going to put something together for that obesity paradox, which I found kind of interesting. Here is a short list of references I used to put this presentation together. And I really thank you for joining me. Thank you so much, and you have a great day.